Welcome to the GOTA virtual conference. Scan the QR code on the left to participate in our silent auction. The silent auction will run from October 1st to October 29th of 2020. Scan the QR code on the right to go to the GOTA online store. Thank you to our 2020 sponsors. Platinum level sponsor, the Shepherd Center. Gold level sponsors, All About Kids Therapy Services in the University of St. Augustine. And silver level sponsor, Hanger Clinic.
Tonight's presentation, we have understanding the importance of upper extremity anatomy for occupational performance. Please remember to complete your assessments when you are done with the course. That way you can get your continuing education credits. Right now, I would like to introduce to you Professor Carolyn Podolski. She has over 33 years of clinical and teaching experience in occupational therapy. She holds a bachelor's in occupational therapy, a master's in motor learning, and is currently pursuing her post-professional doctoral degree at Boston University. She's practiced in a variety of clinical areas, including inpatient, outpatient, home health services, and public school systems, before she joined the faculty at Georgia State University at 2015. She's co-authored 2 publications, and she has presented on several topics at the state and local conferences. Professor Podolski is presenting tonight with Dr. Chen, an assistant professor at the Department of OT at Georgia State University as well. She's from Taiwan, where she received her undergraduate and her master's, and received her PhD in biokinesiology from the University of Southern California. Dr. Chen's research interests focus on upper extremity rehabilitation in individuals with neurological disorders, such as strokes and Parkinson's disease. She's glad to have the opportunity tonight to present and share what she has learned in upper extremity anatomy. Ladies, I am looking forward to y'all's presentation this evening. So take it away.
From her. So we are looking at the role of the upper extremity anatomy in a variety of different medical conditions and looking at the evidence to support what we do. So we're looking at the anatomical structures and evidence-based interventions. So the 4 major topics we're covering this evening, we're looking at flexor tendon injuries, carpal tunnel syndrome, distal radius fractures, and rheumatoid arthritis. So a variety of conditions that you'll see at a pretty regular basis if you work in any type of hospital or outpatient setting. And when you think about those conditions, all of those things affect the hand or the arm in some way, shape, or form. And our hands are so important to everything that we do that's functional in life. So we're going to start, I'm going to start with the first section on flexor tendon injuries. And this was really the best picture I could see. I apologize that it's the middle finger, but we're talking about injuries to flexor tendons. So when you think about where that is and what causes it, the most common cause of flexor tendon injuries are lacerations of someplace within the hand, the forearm, or the wrist area, most distal part of the forearm. A lot of times it's with knives or other sharp objects, so it's often a laceration. It can be a tendon rupture due to wear and tear. If you think of conditions like arthritis, where you have a lot of bony fragments around joints, and you have tendons every time you move a muscle, the tendons will cross over and they can get worn down and they can get torn. There can be a tendon avulsion where it's just ripped apart. There can be a separation at the tendon and muscle interface, and so the tendon is no longer connected appropriately to the muscle itself. So when the muscle contracts, the tendon's not doing its job and moving the digits. Now, flexor tendon injuries themselves are relatively rare. It occurs in about 5 out of every 100,000 people, but they can be very debilitating, and if you're in any type of hand clinic, you're definitely going to see tendon lacerations. And depending upon the location of the injury and if it's complete or incomplete, there's different interventions for it. So the implications resulting, it'll often result in inability to actively flex a finger. If you don't have the muscles that will allow you to bend or flex, it causes inability to flex at the wrist joint, in the metacarpal or IP joints, depending upon, again, the location of it. So when you think about any type of hand injury, you want to look at the flexor zones of the hand. So the hand is divided into multiple segments, and you have different structures that are apparent in these different areas. So if we go to zone 1, it's the distal end of the digits, and it's really anything that's distal to the insertion of the flexor digitorum superficialis, which is going to be here in the middle phalanx. So that's zone 1. Zone 2 is also called no man's land, and it's a pretty tricky area. Zone 2 runs from the proximal end of the pulley system, we'll talk about that, and all the way to the insertion of the flexor digitorum superficialis, which we know is in the middle phalanx here. So zone 3 is here in the palm. It's the distal ends of the carpal tunnel and at the A1 pulley, which we'll be talking about. And then 4 is the carpal tunnel itself. And then 5 is the proximal to the wrist. So there's a bunch of wrist tendons in through here that we'll talk about. And then of course, you can also have injuries to the tendons of the thumb. So we have T1 or thumb 1 would be proximal, T1 would be distal to the thumb IP joint. T2 is distal to the thumb MP joint. And thumb 3 is the thenar eminence itself. Okay. You could also have injuries way over on the medial side in the hypothenar, just depending upon the length of the laceration or the injury. So the structures involved, if you look at this, it's a laundry list of structures. Any one single injury can cause a lot of damage. So again, depending upon the zone, you're going to have different structures, and we'll look at those. I just do want to warn you that we will be looking at cadaver dissection pieces. So I just wanted to warn you ahead of time, and that's coming up soon. So depending upon the zone, you could have problems with the carpal ligament or the flexor retinaculum, and you know the flexor retinaculum is going to hold all the tendons and nerves that run through the carpal tunnel. You have that beautiful palmar aponeurosa, which is a thickening of soft tissue that really helps hold everything down in the hand. There's the flexor digital sheath, that pulley system with the annular and cruciate ligaments that hold the tendons down to the bones of the digits. Of course, we have our flexor digitorum superficialis and flexor digitorum profundus tendons we'll talk about in detail. We also have the wrist flexors, your flexor carpi radialis, flexor carpi ulnaris, and palmaris longus. Then you have your thumb long flexor, your flexor pollicis longus, and of course it can, any injury, flexor tendon injury could also affect the thenar or hypothenar eminences and the muscles there. Injuries can also, these lacerations in this anterior surface of the palm can cause a lot of vascular problems. So it can affect the vascular supply, either the radial or ulnar artery if you're talking in the forearm, or the superficial palmar arch, and then the common and proper digital arteries that are in the hand. It can also affect nerve supply, the median and ulnar nerves, and the common and proper digital nerves, which we'll go back and look at. So we're going to start anterior surface, of course, superficial to deep. So the superficial layer of muscles in the forearm are your wrist flexors primarily. And we'll see here if we start on the radial side, move over to the ulnar side or lateral to medial, you'll see we have the pronator teres, That one's usually not involved because it's much higher. It's more proximal in the forearm. But now we have these important tendons. We have our flexor carpi radialis, our palmaris longus, and you see its insertion right into the palmar aponeurosa, and then flexor carpi ulnaris. And this is just another picture of the different origin sites of the flexor carpi ulnaris. This part, all right.
Insertions, talk about their actions, their nerve innervations. We're going to find some of the blood vessels. We're going to start with the superficial level, and we know there are 3 levels in the forearm: a superficial, an intermediate, and a deep. So we'll get to all 3 of those.
Okay. So now we go back to the. Okay. So now we are at the intermediate layer. So now we're looking at the muscles that are the muscle that's a little bit deeper, and that is our flexor digitorum superficialis. And it's a wonderful muscle, a large muscle with a large origin, and it's going to run, the big muscle belly is going to, the tendons are going to run through the carpal tunnel, and they're going to travel down each of the 4 digits, and then the tendon itself is going to split in the middle of the middle phalanx and insert on the middle phalanx, and it's going to split open to allow something else, the profundus, to come through. But you'll see these 4 very individual tendons. Okay, next. And I'm going to try this.
All right, so to get to the intermediate layer, we cut, and now we're going to reflect back the superficial layer. So again, we have our flexor carpi radialis, so we'll cut and reflect that. Then we have palmaris longus, we'll reflect that. And then over here, we have flexor carpi ulnaris, and we reflect that. So now we have a cleaner view of the structures underneath. We see the intermediate layer, we see this one big muscle in the middle here. It's one big muscle belly. We could reflect these back proximally also. See how these muscle bellies are separate from the ones underneath. Okay, but there's still this fascia. There we go. Reflect that back a little more. Okay, so this is our flexor digitorum. It's going to go to the digits, superficialis, because this muscle is more superficial. The ones that go to the fingers, this is the more superficial of 2 muscles that go to the digits. So flexor from the medial epicondyle to the digits, flexor digitorum superficialis. It has 4 separate tendons that are going to pass through the carpal tunnel, if you remember that, and will insert, it's going to travel up the metacarpals, and then it's going to insert on the middle phalanx. So at the proximal phalanx, the tendon's going to split and form a Y. And, whoops, and that's where it inserts.
Okay, and then there's a second one.
All right, so we reflected back the middle layer, flexor digitorum superficialis, and I just took the insertion, the muscle belly and insertion ends, tendon ends, just kind of clipped them back out of the way, and now we can look at the deep layer of the anterior surface of the forearm. So we see 2 muscular structures right away. We see this one that is very radial. You can see it's going right up to the thumb. It's a nice big muscle belly. Starts to have a nice strong tendon there. This is the flexor pollicis longus. It's an extrinsic muscle. It originates in the forearm, crosses over the wrist, and the tendon runs all the way down the thumb, and it's going to insert on the distal phalanx, and its prime action is going to be IP flexion, but as you all know, because it crosses the wrist, it crosses the carpal metacarpal joint, crosses the proximal interphalangeal joint, it will assist in flexion of all of those actions, okay, on all of those joints. So this is our, again, flexor pollicis longus.
Oh, okay. And all right, we'll just keep moving. There's also then the deep flexor digitorum profundus is also in that layer, but I must not have recorded quite enough of it. I make those videos because I teach the gross anatomy course for the OT students, and I like having, I found that they have a difficult time figuring everything out if they don't have kind of something visual ahead of time. So I started recording them, and then I display them for the students to watch ahead of time, so then when they go in to do the dissections, they're able to follow along. So we did both of these already, Kian?
Yes.
Okay, so now we're looking at the palmar aponeurosa. And it's this triangular, very thick, very strong tissues that hold all the muscles in. You'll see that it's also what the palmaris longus inserts into. And again, that can be damaged, and there's some really important structures just inferior, just deep to this. So we're going to talk about those structures next. Okay, next slide. So just deep to the aponeurosa, you're going to have some really important structures. We have neural structures and vascular structures, as well as muscular tendon structures. So on the radial side, we're going to have the radial artery and its branch that contributes to the superficial palmar arch. On this ulnar side, we have the ulnar artery, which is our prime component of the superficial palmar arch. You're going to see all of their branches coming off. So these are the common digital arteries. And the common digital arteries, when they get close to the digits themselves, will split. And then they turn into the proper digital arteries. And they're going to travel very closely with the nerves too. So we've got this median nerve, which also travels through the carpal tunnel. And it's going to send its common digital nerves, which will then branch into proper digital nerves when they actually travel down the digits. And then over here, we have the ulnar nerve. Okay, so we've got our thenar muscles and our hypothenar muscles, and we've got our long tendons. We have the tendons of the flexor digitorum, superficialis and profundus, and over here we would have the flexor pollicis longus. Okay. Then you can see some interesting things here. You see this flexor retinaculum, and you see how the tendons with their synovial sheaths travel through here. We have the superficialis, which has been cut, so you can see that underneath the superficialis is the profundus. The other thing that you can see nicely here are the lumbrical muscles. Some are bipennate, coming from one tendon, and others are, unipennate, coming from one tendon, and then the other two are bipennate, thank you, coming from two different tendons, and you can see where they insert. And then of course we have the long flexor pollicis longus tendon, okay? And so I think this is our last video. I'm sorry the timing is off on these. This one's a little longer, but it has a lot of good stuff.
We're looking at the hand in a little more detail today. So let's go back to the thenar eminence here. So thenar eminence is at the thumb. We have three different muscles. We have this first big one in the middle. So this is your abductor pollicis brevis. So when we reflect it back, we're we're going to see that there's another muscle deep to that, and this muscle is your opponent's pollicis, and that leaves this little guy here more central. So this one is more on the ulnar side, and that's this guy, and this is your flexor pollicis brevis. So we have abductor pollicis brevis, opponent's pollicis, and flexor pollicis brevis. Now, over here on the ulnar side, or the medial side, we have the same three muscles, but these are for the digiti minimi. So over here on the most medial side, okay, this is our abductor, digiti minimi, abductor, digiti minimi, okay? Then the one that's right in the palm, right here, it's small on our little lady here. This is flexor digiti minimi, straight plane movement here. And then, when we reflect these back more, you see that there's muscle fibers much deeper right on the bone, and that's opponent's digiti minimi, right underneath there. So that's our thenar and hypothenar muscles. Now, the other thing that we see really nicely here, again coming from our ulnar artery here, here's our ulnar artery traveling with our ulnar nerve, and it's sending that branch through the Guillen's canal. So we've got this ulnar artery and nerve traveling, and here we see the ulnar artery is the prime component here of your superficial palmar arch. It is traveling with the nerve, you can see that here, and these branches are going to travel together. So the first branches coming off of the superficial palmar arch will be your common digital arteries. So they travel up the length of the metacarpals. So this is your common digital artery, and it is traveling with your common digital nerve from the ulnar side here. As they travel distally, and you see them coming onto the digits, they will turn into your proper digital artery and nerve, and we can see them in here. They were kind of attached inside the skin, and that's what we see here. Okay. So then I want to look a little more at, I think we looked at this. On this finger, we've removed the flexor digital sheath, and we can see very nicely how the superficialis tendon, the tendon of the flexor digitorum superficialis, cuts or splits, and it sends two tendon insertions on the lateral and medial side of the middle phalanx, and then that allows this deep tendon, or the flexor digitorum profundus, to come out here and go all the way to the base of the base of the distal phalanx and insert, and it's going to allow for flexion of the DIP joint. Whereas the superficialis, because it inserts on the middle phalanx, is going to allow for flexion of the PIP joint. Okay, then we cleaned up another digit, but we didn't take it down so far. So what we're seeing here are how this flexor digitorum superficialis and profundus are wrapped together, and you see this kind of white, shiny structure holding these tendons together. And this is your fibrous digital sheath, or your flexor fibrous digital sheath. And if you look very carefully, you'll see things that look like loops, okay? This is coming all the way around. This would be an annular ligament, and you can see things that look a little more X-shaped. Let me see if I can identify it a little clearer. I think that's another annular one here. So they're not as easy to see, but they definitely are there, and they're holding tight. And just see what you can find. So try to clean off and look at the tendons on one digit, and then see if you can find the fibrous digital sheath on the other. And you should be able to at least see the annular ligaments really clearly. let's see, another thing that we can see on this hand, I don't want to destroy these structures, so we're going to kind of work around it. We're going to see these muscle fibers inside the hand, okay? As you see, they're between the flexor tendons here, and if you really look, I don't want to break that. This would be the tendon of your superficialis, and right underneath it is the flexor of the flexor digitorum profundus. And coming from the profundus are these fibers. Maybe stand where I am. And you can really see right here, these muscle fibers are actually getting their origin from the tendon of the flexor digitorum profundus. So this is your lumbar, okay? I'm not going to cut these structures to look for the pads or the palmar interosseae, but if we flip the hand over, we can see
We can stop now. We're not looking at the
the dabs back here. And we see some nice nerves. But in between the bones, interossei, between bones, you're going to see these dorsal interossei, or dabs. Okay?
And you can turn it off now. Thank you. Thank you so much. I greatly appreciate it. Wasn't it kind of fun looking at that stuff again for some of us after all these years? And I love the comments. It is a great experience to be able to do dissections, and the students really appreciate it. And unfortunately, this past semester in the summer, we weren't able to do dissections because we couldn't meet live in the classroom. So there are some great programs around. Could almost smell the cadavers again. Yeah, that's the only thing. I love teaching anatomy. I don't mind the cadavers. I enjoy it. You know, after all these years of doing it, probably about 8 now, 8 or 9, I can find any structure in the body. I certainly can't find anything on a computer, but I can find any structure in the body. But I didn't miss the smell this summer, let me tell you, not being in lab, but I did miss lab. So we covered all of these things by looking at the cadaver, but what you can see in this picture is the tendons and the way they're wrapped together, and they're wrapped around a synovial sheath. And if you've worked with hands at all, you know the synovial sheaths are very important because they're producing synovial fluid, which will allow those two tendons to glide and slide over each other, which they need to do every time we flex and extend. So the profundus can come out from underneath the split in the superficialis, and they don't get stuck or adhesed. And that is a big problem with flexor tendon injuries, is adhesions of your flexor tendons. So that's that. And again, you can see how it travels through the carpal tunnel. That's fine. That's good. And then what you can see here, again, this is that fibrous digital sheath composed of, also called the pulley system. And it's composed of these annular ligaments, which hold down larger segments at a time, some of them, and then also your cruciform, or the X-shaped ones. The X-shaped ones are going to allow more for movement. So, and you can see these little palmar plates that over the joints, which allows these tendinous fibers, or these ligamentous fibers to attach into something. So this whole structure is held very tightly to the bones, so you don't get bowstringing, and you have really nice excursion of the digits. Okay, next. So the last thing that I wanted to mention when it comes to the whole idea of the digits and the long tendons and the way they all work, the tendons need blood supply. Without blood supply, the tendons would have lots of issues. They would become necrotic, they'd become very stiff. So there's these beautiful little structures called vinculi, and they go to both the profundus as well as the profundus as well as the profundus as well as the superficialis, and they're just some of this ligamentous tissue that blood vessels travel through to get to the long tendons. And so when you think about flexor tendon injuries, if it's a deep enough injury and it cuts through the flexor tendons, if it damages the vincula, it doesn't respond as well. There's a lot more issues involved if the vincula are damaged. So you'd have a poorer result. Okay. All right, so what's the impact on occupational engagement? When you see how many structures are involved in the hand and how easy it would be to damage multiple structures at one time, including muscles, tendons, ligaments, nerves, you name it, vascular supply. So if you have impaired function of the hand, it's going to make a lot of things difficult. Your ADLs, your IADLs, leisure activities, work-related activities, sleep, because there's a lot of pain involved. And a lot of times with these injuries, you have to wear splints and you have to be very careful, have very regimented activities and movement and exercise programs. And it can impair social participation because of pain, because they spend a lot of time kind of guarding it and protecting it, and they just don't want to go out. So it can affect a lot of different things. So just typical rehab strategies that we use with flexor tendon injuries. There's a lot of different splinting protocols, different ways to splint depending upon the injury. But on the flexor side, you don't want initially a lot of active flexion. We'll talk about that more. But the splints will keep the fingers positioned in a way to keep them safe. There's different range of motion protocols that we'll talk about briefly. Some therapists can use modalities for healing, for swelling. It's important to teach compensatory strategies for basic ADLs and IADLs. If they're not able to use one of their extremities, we're going to have to help them figure out how to do the things they need to do. And of course, some tendon gliding activities. Okay. And the psychosocial, thank you, Amy. Yes, the psychosocial impact is really huge. They can have a lot of fear, a lot of trepidation. They're looking at their hand and it looks so different. So they know there's going to be scarring. Yeah, sometimes the events were pretty traumatic. They can be crush injuries, so they may have a little PTSD about the event that caused the injury itself. So indications for treatment. What do you need to know in order to treat somebody with flexor tendon injuries? You have to have a good knowledge of the deficit. You have to understand wound care because there's a lot of open wounds here. You have to understand the different types of exercise programs and post-operative movement precautions. There's just a lot to know. There's a need for protective positioning, again, so they don't overstretch those flexors. There are custom fabricated splints that therapists can make, but there's also some that you can just buy buy from the markets. So they're specifically designed. The specific design really depends upon which tendons are involved, the zone of the injury, what type of repair. There's a lot of different surgical repairs, different types of wires that they'll use or to do the repairs. There's different post-operative protocols depending upon the surgeon and how they like to do it. Patient sophistication, how up are they? Are they willing to do some research and find out about this type of injury and follow instructions and go online and find out what they can do and what they can't do? So generally, splints are designed to prevent tension on the tendon while it repairs. So it allows those cut ends to be close together so they're opposed. And as the healing is taking place, and if all of a sudden they would go into full extension, it could just pop the tendon repairs. So it's really, really another fear. So the clients can be very afraid to move at all because they don't want those tendons to pop after they repair. But that can cause problems too if you don't have some movement. That's when you can get adhesions between the different tissues and the different tendons, which could cause a lot of impairments in movement. So let's see, there's a lot of other things that occur because of the injury. There's going to be upper extremity edema, pain, joint stiffness. There's going to be problems with the excursion of the tendons, decreased range of motion, weakness, which are going to cause a lot of functional issues. Think about what we do all day, every day. A lot of us are on computers. We're typing. We're, we're taking care of children. We're cooking. We're cleaning. We're driving. We're doing what we need to do, and it usually takes two hands, good functioning hands, to do those things. So there's functional impairment in many different areas of self-care, home, community, leisure, work activities. There's going to be issues of decreased skin integrity around the wound and the incision site. There's always a risk of infection, scarring, and people have to understand the contraindications and precautions for the different treatment protocols. You have to consider whether the vincula that we talked about were damaged. That would affect the healing of the tendons because they wouldn't have as much blood supply. Okay? So I found something online that I thought was interesting. It was, let's see. Oh, it's right here. Okay. So there are two women orthopedic surgeons, and they just posted this on OrthoBullets. So it's a website, and they had some really nice information. Now, if you go on this website, it covers all sorts of hand injuries. And they do a really good job. They give lots of detail. But the problem with it is they didn't put their sources. So I don't have the original articles that they talked about, but I do have some articles and some different things coming up. But you can get information from websites, and these are, board certified hand surgeons. But it would be really nice if they would post where they got this information from. If they posted the sources themselves. So, but this is good general information. When you look at flexor tendon injuries, what are the symptoms? Well, you're going to have loss of active range of motion, depending if it's a full laceration or partial. So you might have no active flexion, or you may have weakened flexion. There can be sensory changes if the nerves are involved. There could be vascular problems. So you could have some changes in coloration and temperature of the skin. So what's another thing that you would do? You would do a physical exam. So you're going to observe the resting posture. Just by looking at the resting posture, you can get an idea of what tissues could have been involved. Is the hand doing its normal cascade when it's relaxed, and have the nice arches of the hand? Assess for skin integrity. Where is the laceration? How deep is it? You might be able to identify localization of what tendon is injured, if it's a crush injury or something. And look for the evidence of trauma. So also neurovascular problems. It's important, given the close proximity of the tendons to these neurovascular structures, the arteries, veins, and nerves. So there could definitely be weakness, numbness, tingling, those types of things because of neural problems, not just because of the tendons themselves. Okay? So they also, at this website, they also talked about the difference between non-operative and operative management, medical management. And a lot of it depends upon the extent of the injury and what tissues are involved. So for non-operative, it's when there's partial laceration of less than 60% of the tendon width. If it's more than that, there's too great of a chance that it will continue to tear. So they opt typically for surgery. So initially you'd be doing a wound care and some early range of motion, and you'd follow a protocol that the surgeon would recommend for sure, because you wouldn't want to do additional damage. But at the same time, you want to make sure that there's they still have some excursion of the tendons. So if it's operative care, it's because they're typically because it's greater than 60% of the tendon width, and they need to have very controlled mobilization. You can't just let them start flexing and extending their fingers. And also if there's reasons for flexor tendon reconstruction or an intensive rehabilitation post-op, if it's an older injury that never healed well, so a failed primary repair, chronic untreated injuries, those types of things can be much more complex and need a lot more rehab. Okay. So the postoperative controlled mobilization has been a major reason for improved results in tendon repair. Some of us are old enough to remember when they were immobilized initially for the first couple of weeks, and they found that the complete immobilization results in a lot of poor healing and a lot of adhesions and those types of things. So they do have controlled mobilization, where they can do the extension but not do active flexion. So there may be a passive flexion where they can do it themselves, or there may be rubber bands or different systems, pulley systems that will allow for the flexion of the digits, and then they can actively extend to a degree. It'll be blocked, so you don't want the finger flexor tendons to be stretched. You'd also want to make sure that you don't get wrist extension and of course your finger extension simultaneously, so they may put the splint in a slightly flexed position of the wrist. So there's different protocols to follow. So, but it does seem that there is evidence, quite a bit of evidence, that this early controlled mobilization will improve tendon healing, and it limits the restrictive adhesions, and it leads to improved tendon excursion. Yeah, Barb's saying when she first started treating folks, yeah, the surgeons kept them in a resting splint. And then we had to treat them for months because they had so many issues. So the protocols, there may be, protocols for immobilization when people who really can't control what they're doing, children who don't understand, patients who are non-compliant for a variety of reasons, cognitive issues or the such. So then you can apply casts and splints and position appropriately so the things can heal well. But then you're going to have to work pretty hard once they're mobilized. You'll probably find some adhesions, and there's going to be a lot more rehab needed for those people. Okay. So they talked about the Duran and Kleinart protocols a little bit. These protocols have been around for a long time. There have been adjustments to the protocols. With the Duran protocol, it calls for low force and low excursion. They want active finger extension, but with the passive finger flexion, and they keep them in a static splint. Whereas the Kleinart is looking, they still want low force and low excursion initially, and then they're looking at the active finger extension, and they'll use more of a dynamic splint-assisted passive finger movement. And there's other protocols. Some people will do the early active motion, so they're using a moderate force and getting potentially high excursion. But again, you have to be so careful with the ultimate position of the fingers and the digits because of the flexor tendons. So they'll do a dorsal blocking splint to prevent the extension of the wrist and fingers simultaneously. And they can also do just some exercises to work kind of isometrically, perform a place and hold exercise of the digits to keep blood supply going and to keep some muscle strengthening of the muscle bellies themselves. Okay. So the most common complications, and again, this is all from that website, but all of this stuff comes from good research articles, and I do have some coming up. So the tendon adhesions, they're the most common complication following flexor tendon repair. It's primarily, it's very high risk in those zone 2 injuries because that's where your pulley systems are. So, and that's where your flexor superficialis and profundus are joined together, and you've got the fibrous digital sheath that wraps around And it just is a very challenging location. So with the tendon adhesions, the treatment options are, of course, hand therapy, working with a PT or an OT for hand therapy. Of course, I should only say OT, but PTs work in hand therapy also. So the different finger gliding exercises, massage, those types of things, maybe some modalities. But the surgeon may choose to do tenolysis, where they go in and try to remove some of the scar tissue and the adhesions themselves. But every time you go in and do a surgical repair, there's always a chance of more scar tissue. But they'll do this 4 to 6 months after the tendon repair if there is significant loss of excursion. And there's always chances of a re-rupture. And there's somewhere between a 15 and 25% re-rupture rate. And that's a real complication because they have to go in and do another surgery oftentimes. Again, increased chance of infection and those types of things. And another problem that's found, complications of tendon repairs, would be joint contractures. It could be at the wrist, it could be at any of the joints of the digits. You can also find problems like with swan neck deformity, trigger finger, lumbrical plus positions, those types of things that really limit functional mobility of the hand. Okay. So I found some nice articles. I have a systematic review, a couple of those I think in this, and a couple other articles. It's just kind of fun looking around for the evidence. Some's a little newer, some's a little bit older, but I tried to get as most recent as I could. This was a fun one. This was actually in a Turkish journal of physical medicine and rehabilitation. And, I'm just trying to see what I did here. Is it the Indian journal or the Turkish journal? This one is the Indian journal. Evidence, oh, I think I did. Oh, sorry about this, guys. It's been a long day. So these are the articles that I found that we're going to review. So one is from an Indian journal. It's outcomes of early active mobilization after flexor tendon repairs. Then the effectiveness of occupational therapy with adults, a systematic review. And then I thought the third one was kind of fun. I enjoyed that. It's looking at the use of the Canadian Occupational Performance Measure as a good, valid tool, because a lot of the tools out there were designed by surgeons to look at the repair and what the problem, and when a repair is successful. So that's a neat article we'll talk about. And then the functional outcome after flexor tendon repairs of the hand, and that was in the Turkish journal. So that was pretty cool. Okay. So the first one we're going to talk about is the outcome of early active mobilization after the flexor tendon repairs. And it was looking at the restoration of the function of the digits after the flexor tendon injury. And it found that the problem, the biggest problem is getting the function back. So the most variables except mobilization protocols have been established and defined in the past. So there's a lot of things that they know work well in surgery, the different types of procedures, the different types of threads that they use. But what they don't have a really good idea of, even though there's a lot of protocols out there, what's the best protocol to use that's been established? So it has been proven. Just useful assessment. Oh, I know. Yeah, I love the COPM. I think it's awesome. We push it in our program. My students are using it now with some online things that they're doing. But anyway, so let's see. It's been proven that post-operative immobilization leads to increased disability period, weak tensile strength, which is not good, decreased final functional capacity, stiffness, and deformity. So we know we've got to move these people, but we have to do it safely because we know that on the other end, there's the chance of re-rupture and those types of problems. So Further early postoperative mobilization leads to improved tendon healing, increased tensile strength, decreased adhesion formation, early return to function, and less stiffness and deformity as compared to an immobilization protocol. So we know that's true. So this study evaluated the outcomes of early active mobilization of repaired flexor tendon zones, basically 2, 3, 4, and 5. Okay. We can keep moving. So the thing was to start the rehab process early. So they actually started the rehab 24 hours post-operatively. And they used a program, they adopted or modified the Kleinert's protocol. So they had the wrist following the nerve repair was kept at 5 degrees of palmar flexion, so it would never go into extension to overstretch the finger flexors. And in the cases of ulnar nerve cuts, they kept the MP joints at 90 degrees of flexion too. They did a lot of education with the patients, and they were strictly advised that they could not passively stretch their repaired tendons. They were not to remove the splint unless instructed. They were to avoid holding the hand down in a dependent position, to keep it up for swelling. And they were not to increase their exercises by themselves. They had to get approval from their therapist to do that, or from the surgeon. So next. So the early mobilization showed a reduced rupture rate of 3% as compared to 4% to 17% in other series. They compared it to other protocols that they had been studying. The early active mobilization shows benefits for increased healing rate, tensile strength, decreased adhesion, and formation of rupture. So they're finding support for the other articles. And this study showed 82% excellent to good result, with 9 fair to poor, with just 9 fair to poor. And they used something called the Louisville system criteria. I'm not familiar with that. But so they had a really good success rate, but they did have some issues with some of the clients. Next. So then I looked at a systematic review, the effectiveness of occupational therapy interventions for adults with muscular-skeletal conditions. And it looked at a bunch of different ones, and they had a subspecialty just for flexor tendon injuries. So there was a moderate quality meta-analysis found. Now, of course, you know that the meta-analysis are really good high-level evidence, and Dr. Chen will talk about that more, the different levels of evidence. So a systematic review is a good level of evidence when you want to find what's effective and what's proven to be effective. So a moderate quality meta-analysis found that studies using early active motion protocols yielded excellent or good results in 94% of the cases, which was significantly better than other protocols. And then, although the differences were not significant, studies with the combined Kleinert and Duran protocol, they found some studies that looked at both. They showed the lowest tendon rupture rate compared to early active motion alone, or just the Duran protocol, or just the Kleinert protocol. So there's all sorts of studies out there looking at different combinations of protocols to find the best result. Okay. This is the one about the COPM. So it's construct validity of the Canadian Occupational Performance Measure in participants with tendon injury or Dupuytren disease. So they looked at the COPM, the DASH, which is the Disability of Arm, Shoulder, and Hand Questionnaire, and the MHQ, the Michigan Hand Outcome Questionnaire. So the purpose, and they worked with people who had tendon injuries. So the purpose was to evaluate, to determine if the COPM is a reliable and valid measure to assess outcomes that are meaningful to patients with tendon injuries. Because the DASH, or this MHQ was actually developed, I forget which one, I'm so sorry. Oh, it was the DASH, was developed by orthopedic surgeons. So they're looking at things a little differently than we are, and we want to make sure that the people are able to do functional things. And the COPM is a great way to look at their own personal goals and what they're getting out of the rehab. Okay? So these are just kind of quick reminders if you're not as familiar with some of these. Just generally, the COPM lets the person evaluate what's important to them. So they do a self-evaluation of what's important. So it's a semi-structured interview, and you would ask them what are the most important things, and then you ask them to rate their performance on it. So how well do you think you do this? 1 to 10, and then how satisfied are you with how well you do? So you're really getting a very client-centered approach of what's important to them. And the next one, please. And then the level of importance. How important is this to you? So it's a great tool, and it's interesting. You know, I don't know if I would have thought right away to use the COPM when you're thinking about very biomechanical things. Of course, you think about more of the range of motion, strength, pain, those types of issues. So this is interesting. Okay, next. So the DASH, the disability of arm, shoulder, and hand. I just took a couple of sections from it. It's a fairly long assessment. You can get a mini DASH too, or short DASH, and they're asking the person to decide what they think they can do. So please rate your ability to do these activities. So no difficulty to unable to, and they're pretty functional. Open a jar, write, turn a key, make a bed. So they're pretty functional activities. So this is a good assessment too. Next one. And it does more, gets a little more complicated. Wash your back, pull on a sweater, use a knife, different recreational activities, manage your transportation needs, sexual activities. So it covers a lot of very functional occupation-based things. Next. And then this is all part of the DASH. And then it wants to know more about what are you able to do. During the past week, to what extent has your arm, shoulder, hand problem interfered with your ability? So it's a pretty comprehensive assessment. Okay, next. And then the MHQ, that's the Michigan Hand Outcome Questionnaire. So this is an interesting questionnaire, and it looks at, you know, theory-wise, it looks at the person's satisfaction, their function, their ADLs, pain, work, and aesthetics. So it covers a variety of things. Next. And it gives a lot of questions, and you just have a ranking scale. So I just put a few examples in here. So the following questions refer to the function of your hand or wrist during this past week. Please answer every question. So the following question is going to refer to your right hand or wrist. So they get very specific. How well, overall, how well did your hand work? How well did the fingers work? How was your strength? So pretty specific questions, okay? And you would rank these as very good to very poor. Next. And then same thing, then they ask about the left hand and the left wrist. Next. And then how you're using both hands together. And now they're getting just some very occupation-based functional things. Opening a jar, buttoning a blouse, eating with a fork and knife, carrying a grocery bag, all those different types of things, tying shoelaces. Next. And then again, going back to right and left hand, just more activities, turning a doorknob, picking up a coin, holding a frying pan, those types of things. And they ask the same question. So they ask specifically for the right and the left, which is interesting to see if there's a big difference depending if you're right-handed or left-handed also. I think that's about it. Okay, so what they did, so those are the different assessments that they're comparing. And they want to see if they'll get the same type of functional information from the COPM, and if the COPM has good correlational abilities, good correlation with the other two assessments, which are known assessments, which have been studied, which we know have good validity and reliability. So is the COPM correlational? Does it have good correlation with those? So they had 72 participants, 72 patients who had received post-surgery rehab between, whoops, I have an extra O in there, don't I? Okay, all right, 3 more topics to cover. Sorry guys, I took way too much time at the beginning making a mess of everything. I apologize. So basically all participants had flexor tendon injuries in any of the 5 flexor zones or had Dupuytren's. So they were scored on all 3 of these. And then of course, the more biomechanical things, pain, range of motion, grip strength, pinch. Okay. And the outcomes, they had very good convergent and divergent validity. There was no floor or ceiling effects found using the COPM. The Pearson coefficients and correlation of the COPM had strong, significant correlation with the Michigan hand questionnaire, and moderate, but still significant correlation with the DASH. So it does demonstrate good correlation between the COPM and the other standardized assessments. So it's a great assessment to use. That's that one. And I am done, at least with part of it, okay? So thank you so much for being patient with me. And Dr. Chen is gonna talk about carpal tunnel syndrome. Do we wanna do just questions at the end, or should we do them after each section? What do you think?
Right now, we don't have any because you've done a great job checking the chat throughout.
Okay.
Does anybody have any questions now? All right.
I wish we, great. I was gonna say, I wish we had more time because you guys have a lot of experience in this. I'd love to hear what you think about the different protocols and what you have found helpful and everything. But we need to keep going or we're gonna be here till midnight, folks.
I just had one quick one, and that was way back when you were pulling from the website that had the surgeons that didn't provide their sources.
Yeah.
Did you have a sense of how many participants or subjects they had in their studies? Did you get any sense of that or not?
No.
I figured not, or you would have reported it. Okay.
Yeah.
You've been doing a great job, though. Thank you. Keep
Oh,
rolling.
thank you. I'm so sorry for my lack of technical knowledge.
We like your expertise. The technical we can deal with.
Okay, thanks. Okay, Dr. Chen.
Dr. Chen, it looks like you need to hit unmute.
Oh, yes.
There you go. Great.
I've been talking the whole time. Okay. So hi, everyone. So yes, I'm going to continue talking about carpal tunnel syndrome. So I will start talking about the related anatomical structures, and then I will share with you some of the evidence that I found regarding the specific intervention that is more relevant to OT, what OT can do, and then talk about what the research found. So basically, let me turn on this. So as you know, the carpal tunnel syndrome is formed by the carpal bones. So you can see the structure over here, and it's covered by the flexor reticulum. So I got a message to say the host has asked me to start my video. Oh, okay. Yes. So hopefully you can see me now. All right. So again, the carpal tunnel syndrome formed by this carpal bones, and it's covered by the flexor reticulum. So that's why it formed a whole space over here. And then the important structure going through all this, going through the tunnel are those 4 different structures. The tendons for the flexor digitorum profundus, the flexor deterrens superficialis, the flexor pollicis longus that Caroline just went through. So it's all over here, those 3 different tendons. And then one of the most important thing, of course, is the median nerve that is also here. So that's the whole 4 important structure that's go through in the carpal tunnel syndrome. So, so we're going to talk about the carpal tunnel syndrome that is very common, and it's caused by the pressure that's on the median nerve specifically. And it can cause by any of like so many different reasons. As long as it squeezes or irritates the median nerve, then the patient or any of them will have the syndrome. So it could because the patient probably do the repetitive motion, like, you know, right now everybody's at home, then you use the computer a lot. So then you probably position your hand not very good, in a not very good way. So you probably, you know, spend too much time typing, use the mouse. So then that compresses your median nerve and irritates it. And also because probably you're at home so much, so you're just like, you know, cleaning a lot, and then it's like wrinkling off the towel over and over again. So that also probably gonna be one of the reasons causing carpal tunnel syndrome. The other thing would be like the obesity or RA and then pregnancy. So basically just that space gets compressed or smaller, so that compress the median nerve. And some of the patient also born with more smaller carpal tunnel space, so that is also part of the reason. So I'm actually one of them. So I have relatively small carpal tunnel syndrome, carpal tunnel space. So when I was pregnant with my daughter, so even though I was in the very early stage, like, you know, week 20 something, I already started showing carpal tunnel syndrome. And then I had that whole syndrome the whole time until like 2 months after I gave birth. So it was pretty painful. And then I do experience all these things, the numbness, the tingling, the pain, the weakness for all of them. So as you might remember, the median nerve has the sensory contribution. So you might remember the 3.5 fingers. So that would be the area that the patients will feel the tingling, all those, you know, uncomfortable sensation. And then one more thing is that the pain and the tingling can actually travel up to the forearm, to the shoulder, because that whole nerve is irritated. And then also the other important thing is the median nerve also have the motor innervation. Specifically, one is the thenar muscles and the lumbricals, the 1 and 2 lumbricals over here. And then the thenar muscle that Caroline just talked about in the video that she showed you. So people will experience some weakness if they have trouble doing the thumb movement, all those kind of things you can imagine. So following up, I'm just going to talk about some of the evidence-based intervention. So most of the common treatment, I guess a lot of you probably have much more experience than me on this part. So I'm going to focus on these 3 particular treatments: the mobilization, the manual therapy, and splints, those 3 parts. So I try my best to find the more like relevant, most recent systematic review or meta-analysis studies or RCT studies. So this particular one from 2012 is a systematic review. They include 16 RCT studies, and total they have around 1,500 patients. They basically trying to compare those studies that use mobilization. They didn't have a very specific one that they focus on. They basically include all different kinds of mobilization, and compare with the control group that's either no treatment or different types of mobilization or other non-surgical intervention. And this specific systematic review, they focus on people who have mild to moderate symptoms of the carpal tunnel syndrome. And what they found is sort of like a little bit unfortunate, is that they found that there's a very limited evidence to suggest that the mobilization has some effect. And then because there are so, you know, people are people do things so different. They probably, use, one of them use the carpal bone mobilization, one of them probably use the nerve mobilization, and then compare with so many different things. So they don't have a good comparison to have a strong conclusion saying that, whether the mobilization is effective or not to help people to decrease their symptoms or improve their functions. So that is why I put it here, say it's limited evidence suggests that the mobilization has some effects. And then also because they compare different types of mobilization, but still no evidence supports that one particular type of mobilization is the one that we should go for. And then there's a more recent article that is doing the meta-analysis. So this particular article, they focus on the neuromobilization. So this one, they compare the neuromobilization with all the other non-surgical treatment, like the usual care, the spleen, the ultrasound, all these things I listed down here. What they found is the neuromobilization was not effective to reduce people's, for example, their function, to improve their function or to decrease their symptoms. What they found is that the neuromobilization probably gonna help to improve their neurophysiology effects. For example, like the edema will be better controlled after the neuromobilization. So these are the two articles I found. That's sort of like the high level of evidence. The one is the systematic review, one is the meta-analysis. So like their conclusions or overall, it shows that there's really limited evidence to tell the therapists tell us to say, okay, mobilization is the treatment that we should go for. But doing those mobilization skills or a treatment probably going to help patients to improve their physiological symptoms like the edema that I mentioned earlier. The second part that I'm going to talk about is focusing on the manual therapy, talking about different massage and exercise. So this particular one, for this particular treatment, I didn't find the systematic review or meta-analysis, but I did find the RCT studies. Particularly this one is published in 2010. They did a specifically called myofascial release. That's like the compression therapy. So what they describe is that they press or apply the pressure for 5 to 15 minutes on certain trigger points. And for example, on the pronator teres, the axilla, or the biceps, compared to the control group that provide the compression therapy on the non-relevant points. What they found that is the intervention group, that is the one that had the compression therapy on the specific trigger point, those participants actually did show greater improvements in symptoms and function at 6 months follow-up. And the next article is also an RCT study. It's a relatively bigger sample size. It's published in 2012. So this one is also very interesting. So they have the intervention group and then compare with the control group. Both groups had the splint, and then both groups did receive the tendon and nerve gliding education. But the intervention group sort of like getting this extra, the self hand massage. It is a home massage that one of the therapists is going to show the patient how to do it, and then ask the patient to do it every single day for 6 weeks. And then what they describe in the article is that the massage is actually kind of short. It's only like 2 to 3 minutes, and that covers a lot of different skills. For example, like this particular average one that's talking about the circular stroking movement for like 30 seconds, and friction massage, like it's very deep and transversely massage. That part is like 60 seconds. And then another one that is like talking about like skin rolling or picking up, squeezing, that kind of massage skills for 30 seconds, and shaking for 30 seconds. So people, the patients are asked to do this kind of massage every single day for, again, 2 to 3 minutes per day for 6 weeks. And after 6 weeks, what they found is that the intervention group, this group who got the massage, showed better strength and functions, and then improved nerve conduction and decreased pain compared to the control group. So overall, what I conclude from these two articles is saying that the manual therapy, those kind of massage or the skills, can improve strength, their function, and their also decrease their pain in individuals with carpal tunnel syndrome. The last part that I'm going to talk about is about the splint. So this part, I found one systematic review article. It's published in 2012. They include 19 RCT studies. Basically, that's cover like more than 1,000 participants. What they did is they compared those intervention group who got the splint compared to the control group who either didn't get any treatment, or compare with different design of the splint, or different wearing time or wearing schedule, or other non-surgical intervention. So what they found is that the intervention group, even though that they show some improvement, but still only one article that is very limited evidence showed that the night splinting has some short-term effects to help people to improve their symptoms, the carpal tunnel syndrome. And then that article, unfortunately, is relatively low quality. They didn't actually specify how they randomized those patients, and didn't have very good explanation. So overall, they suggest that there's, again, limited evidence to show that the night splinting is helpful. And then also because they also compare different types of splint, and also no evidence supports that one particular type or one particular schedule is the one that we should definitely go for. So this is from the article that is in 2012. And I found a few more that is more recent. This RCT study published in 2013, they compared the intervention group who got the wrist splint, and then compared to the other group, the control group who didn't get anything. So this splint is basically maintain the wrist in the neutral position, but allow the full finger and thumb movements. And what they found is that the intervention group did show better group strength and function and decreased pain. And they also have like higher confidence in self-management to manage their symptoms about the carpal tunnel syndrome. The very last article, I feel like this is kind of like interesting one. So this particular article, they sort of like, do a lot of combinations. So they basically trying to combine to see whether the general splint means that they use the COCAP splint, or the general wrist stretching, for example, like, flex your fingers totally, extend your fingers totally, and then do this wrist movement to the full range, the general stretching that we'll do, compared to the lumbrical stretching specifically. And then I put the picture over here to show that's what they did for the lumbrical stretching. So basically, like the picture, you see that they ask the patient to do the full range and just mainly focus on the lumbricals. And also they do a specific combination with the lumbrical splinting and lumbrical stretching. So this is the lumbrical splinting, mainly that still allow the fingers to be freely moved, but the MCP joint over there is fixed, is stabilized. And then they're just trying to all kinds of combination. And what they found is that the group 2 and group 4, which are the two groups that involve either the lumbrical stretching or lumbrical splinting, they found these two groups did show improvement at 12 weeks. And the group 2 particularly also show significant clinical important changes at 24 weeks. So it sounds like based on their conclusion, they suggest that we should include certain type of the lumbrical stretching or splinting to help people with carpal tunnel syndrome to improve their functions. So overall, this is what I conclude from all the three articles that I found about splinting. So it suggests that the splint are be able to improve functions, strength, and pain in patients with carpal tunnel syndrome. And based on the last article that I was talking about, so they suggest that maybe we should do some lumbrical splinting or lumbrical stretching for people to have like short-term or long-term benefits. This particular one, I just put all the three different type of treatment all together and an overall suggestion together. So generally speaking, so the mobilization, unfortunately, it didn't have enough articles to have a consistent agreement saying that the mobilization or which particular mobilization is helpful to improve people's function or decrease their symptoms. And the manual therapy, I also didn't find any, particular systematic review or meta-analysis. But based on the 2 RCT study, it shows that the manual therapy, like the massage therapy, did improve people's strength, function, and pain. And the splinting probably is the most, the one that has more positive results, showing that it did help people to improve their function and also the strength and the pain. And then again, they suggest specific splinting that involves the lumbricals. So I have all the reference over here, and I also include that in the handout. So if you're interested, you can take a look of all these articles and then get more details. That is it for my part for carpal tunnel syndrome. Any questions for me on this part?
Got a comment from Irma saying that you had a very great presentation. I love the part about the lumbricals. Thank you.
Yeah. Sorry, I know because we ran out of time, so I kind of like spoke very fast.
That's okay. We still have enough time. We'll go ahead and continue on.
Mm-hmm. All right, so Caroline, then that's your part.
Okay. And I'm going to spend a little bit of time. This is much shorter than my other one. So we're going to talk about distal radial fractures. They are more common, and they can have a lot of issues. I'm going to talk about them specifically in the older population, but there's certainly a percentage of young people who have them too because of injuries and falls and accidents and that type of thing. But I'm going to focus on the older population. Okay. So distal fractures are actually one of the most common types of fractures, accounting for around 25% of fractures in both the pediatric population and up to 18% of all fractures in the elderly age group. Information over the past 40 years shows that there's an increased prevalence in this injury. And so when you think about it, you know, why are we having more fractures? So societal effects of these fractures include decreased school attendance, lost work hours, lost independence, and lasting disability for some people. So it's happening more often, and we're finding that it's affecting function and performance in people's lives too. So I think one of the reasons it is happening a little more statistically than it used to, our population is aging. People are living longer. They're living longer with disabilities because the disabilities we can control to a degree, but then they still have weakness and different things that may cause falls, and then falls can often really lead to wrist fractures. Okay, well, I guess I could start my video. All right, so looking at the percentages of women versus men who end up with carpal tunnel, I was listening to Yi-Yen, wrist fractures, so distal wrist fractures, or distal radial fractures. So you can see as people age, it's much more common that they will have distal radial fractures, and it's much more common in women than in men. And you can see by the time people are in their 80s, the numbers have significantly increased. Okay. So we know that distal radius fractures in the active elderly population can actually be one of the indicators that they have an underlying osteoporosis or at least osteopenia, and that they can develop in other parts of their body fragility fractures or what we call pathological fractures. There were some literature, some articles I looked at that were comparing like wrist fractures and the effects of wrist fractures over time and how that can kind of start a downward slide for people as compared to hip fractures, which we've known for decades can lead with, can end up with a lot of other issues and increased mortality rates. So distal radial fractures, we know this event presents a prime point of intervention. If someone is older, they're in their 60s, 50s, 60s, 70s, and they fall and have a wrist fracture, that's a wake-up moment. Have they had bone density testing? What is their diet like? Do they get enough weight-bearing and muscle contraction activities? So it's a great time to really assess what's going on with them and come up with some kind of interventions. So in the year following a distal radial fracture, studies have shown that 5 and 10 times greater rates of vertebral fractures in women and men respectively, and a 60% increase in the rate of hip fractures. So once a fracture occurs, it's in an elderly person, it's more likely they're going to have additional fractures, not too far off in the future. I spent a lot of time working in skilled nursing facilities, and what I would often find is multiple fractures after a fall. Someone would come in with a hip fracture, but they also fell on their wrist and ended up with a distal radial fracture or a distal femur fracture, proximal femur fracture, elbow fractures, all sorts of stuff. So the easiest distal radial fracture to treat is one that doesn't happen. So if we can really try to work on prevention, this is a great place, I think, for OTs to get into primary care, especially with gerontologists, because I think we could help out a lot there. So fall prevention initiatives is really important in active and less than active elderly. And so we know fall prevention is successful and it is cost effective in preventing additional fractures. Okay. So preventative measures. So proper diagnosis allows someone to be diagnosed or assessed for bone disease such as osteopenia or osteoporosis. They could start with different types of medications and calcium and vitamin D to help decrease the risk of fractures, get involved in fall prevention programs, have someone come in and do a home assessment, make suggestions for modifications, those types of things. Okay. So the most common cause of distal radial fractures is falling on an outstretched hand, or foosh. I love that word. I have a foosh. So the distal radius takes 80% of the axial load, but underneath the scaphoid and the lunate bones. So it just puts so much force, your whole body weight falls on it, and just that distal end fractures. And I've got some pictures coming up. The two most common types of distal radial fractures are Colles fractures and Smith's fractures. And it's common to have additional damage with these to ligaments or other soft tissues because bones are sharp. And when they fracture and they slide around and they do damage to soft tissues, ligaments, tendons, those types of things, or nerves even. Okay. So just a little reminder of the distal radius and the distal ulna, and you see this large radial head, and you see your carpal bones here, and you see this nice concavity here of the distal end of the radius and how these nice convexed bones fit nicely into it. This allows for sliding and gliding and movement of the wrist, so it allows us to radially deviate, to medially deviate, to flex and extend. It allows for good circumduction of the wrist. And so you can just see where the scaphoid bone sits directly over the distal radius. And another common fracture with this kind of fall would be a scaphoid fracture also. Okay. So Colles fractures, that occurs when the outstretched hand is out in front of them when they fall. And again, this is common when someone has osteoporosis or osteopenia. It results in an extra articular fracture. So it's outside of the wrist joints themselves, and it's actually the distal end of the radius, which kind of snaps off and pushes dorsally. So another name for this fracture is called a silver fork or silver spoon fracture, because they get this lump on the back of their wrist on the dorsal surface, which looks like a spoon is sitting there. So it results in this extra-articular fracture because of this dorsal angulation and a dorsal displacement of the head of the, head of the femur, sorry, head of the radius, okay? So if the Smith's fracture is the opposite, excuse me, and it's much less common. Most people don't fall like that. So it's a fracture of the distal radius caused by a direct blow when you land on the dorsum of the forearm and you fall with your wrist in a flexed position. So this results in a palmar displacement. So the distal end of the femur, of the radius, pushes anteriorly. And this makes up less than 3% of the distal radial fractures. Okay. So looking at some studies, wrist fractures and their impact in daily living functionality on elderly people, a prospective cohort study. So this was interesting because it talks about how important hand function is in everyday life. And the aim of this study was to assess the role of the individual, looking at their sex, their age, their daily living functional status, and looking at healthcare factors and these and their association with daily living functional changes after a wrist fracture. So what happens to an older person once they do have a fracture of the wrist? How is that impacting them? And so the methods, it was a prospective 6-month follow-up cohort study that was conducted. So people came in with a wrist fracture, they were treated, some had surgical repairs, some had just non-surgical repairs, just splinted or casted. These were all people 65 years of age or older, and it was all due to accidental falls, not like car accidents or anything, but accidental falls. So the baseline information obtained, they looked at the medical records, they looked at the socio-demographic information, how the fracture was treated. They looked at length of stay of hospitalization, other comorbidities. They looked at their social network and level of education. Then they did functional performance measures such as the Barthel and the Lawton IADL scale. And they also looked at the wrist function itself. They assessed using the quick dash. Then they also did the SF-12, the self-report of health-related quality of life, the short form. And they gathered a lot of information. Then they went back after they collected this initial baseline information. Then they followed up 6 months later. Okay. So what they found, they started out with 944 patients over the age of 65 that were admitted to the ER with a wrist fracture. And then within the 6-month period, they found that 21 had passed, 31 refused to participate, 30 were unreachable, 6 were incapable of taking part, and 36 were excluded for different reasons. So that left 820 patients followed up for 6 months. Out of that, 715 patients completed the Barthel at 6 months, and 746 completed the Lawton scale. They found that 680 patients assessed at baseline and 6 months. So they had the follow-up with 680 patients. Okay. So 6 months post-fall, the patients were reassessed by completing the same battery of tests that they were. 89% of the people were women. The mean age was 76 and a half. They looked at the Charleston Index, looking at comorbidities, and 66% of all the participants had comorbidities, including diabetes, COPD, cardiovascular disease, and only 12% were not taking any medications. And there was a certain percentage that had, a pretty high percentage, that had 4 or more medications that they took. And 90% could read or write. So getting a picture of the status of the clients. Okay. What they found was a certain percentage did have decrease in their ADLs and their BADLs. So using the Barthel, 24% of the participants did have decreased scores in the Barthel, and 23% of the participants had decreased IADL scores on the Lawton. So the results showed that most elderly patients who sustain a wrist fracture after a traumatic fall recovered perfectly fine and were able to function well and independently after 6 months. But it also highlighted the fact, when they did some more looking around and more calculations, they realized that these 23 and 24%, because it collected all that data, they were the ones that had the comorbidities. They were the ones that had a lower level of baseline function to begin with. So it lets you know that if the people who aren't as healthy, who do have more issues, are more likely to fall, and then are more likely not to perform as well, to lose function after the fracture. Okay. So then there was a systematic review, and this one was done in 2017, so that was good. It's not that old, and it included seven level 2 systematic reviews, and there were, included 7 level 1s, sorry, and 2 level 2s. They had we found some 5 randomized controlled trials that were also level 1 and level 2. So some pretty high level of evidence. So the evidence supports therapy for short-term effects on pain. There was no evidence to support long-term effects on functional outcomes for exercise or modalities that begin post-immobilization as compared to no intervention after a distal fracture. So I think it would depend upon the population that you're looking at. So I thought that was interesting. It surprised me that they did not find a lot of evidence to support long-term effects of function. So one of the randomized control trials in 2013 found that compared with post-immobilization, that early therapy during immobilization did lead to greater thumb and finger workspace range of motion, but that's fairly limited. You could assume that there was some improved function with that. Then there was a retrospective level 2 study, found that patients receiving early range of motion attended significantly fewer therapy sessions and attained functional range of motion significantly faster. So the earlier they got the therapy, the better off they were. So they improved faster. So that's a good result. Next. There was a systematic review, a Cochrane systematic review, found that even though there was no evidence for greater effects for long-term follow-up, the occupational therapy during immobilization led to better short-term improvements in grip and pinch strength and range of motion. So that was helpful. And there were 2 systematic reviews that indicated that early exercises via either supervised therapy or instruction in a home exercise program had equal benefits. So that was interesting. Oops, sorry. But the one thing that I find is not all patients will follow up and do their home exercises. But if they do, I think it's a great option. In contrast, there were 2 randomized control trials that found that compared guided physical therapy or occupational therapy and patients receiving just a post-surgical home exercise program, that they actually had significant greater improvement. That the people who just did the home exercise program had improved, significant greater improvement in functional outcomes at 6 weeks. So I thought that was interesting and shocking. And I think that was the last of mine, yes. So any questions about distal radial fractures? My take-home message was really looking at the comorbidities, and that it's the first sign that things are can certainly start to go wrong with this population. So it's really important to talk to them about trying to stay as healthy as possible, make sure they're getting regular doctor's checkups, to make sure they are eating right, getting good exercise, that they're really taking care of themselves and doing what they need to so they can have a better quality of life. So no questions? All right, almost done, guys. Okay, Dr. Chen.
Okay, sorry, we definitely going to run over time. It's already 10:28, so I will try to keep.
You mean you can't do this in 2 minutes?
Let's try 1 minute.
Yeah.
So the similar thing, I'm going to go over the anatomical structure for the rheumatoid arthritis first, and I will talk about some of the articles that I found to show the evidence to certain type of treatment that our OT can do. So about RA, as you know, it is an autoimmune disease. So basically your immune system mistakenly attacks your synovial joint, synovial member of the joint. So this is the data from the CDC. It shows that between 2013 to 2015, it is estimated that around 54.4 million of US people actually had suffered from arthritis. That is around 22% of the total population. And unfortunately, it's higher in women than men. And of course, the arthritis prevalence increase with age. And particularly in Georgia, our prevalence is also kind of higher than the average across the United States. It's 24. So we are over here. So sorry, relatively, as you can see on this figure from CDC, sorry, on the East Coast, the prevalence is higher. We are sort of relatively low, but compared to the East Coast, we are still relatively high. So this is the healthy or the normal synovial joints. So we have this joint capsule that is formed by two different membranes. The outside is the fibrous membrane, and the inside is the one that you see in the picture that's in red. That is the synovial membrane. So in the normal situation, this would be the thin membrane. It's highly vascular, and that's the membrane that produces the synovial fluid, which is the fluid that is filled in the articular cavity that is allow us to lubricate and nourishing the joint. But when people have RA, their immune system again attack this particular membrane, the synovial membrane. So that will make the membrane become very thick and inflamed. And then also that make the fluid accumulated very much. So that causes the pain and the swelling. And then further down, if this situation didn't get controlled well, then it's going to further damage and irritate the cartilage and even further to the bone area. So that's why some of the patients that we saw with RA, we see them have the deformity, and then they have the loss of the function. So, of course, the symptom, as you know, usually they start from the smaller joint, like the finger joints, and it is symmetric. So you will have on the both sides, and because the inflamed joint, so usually they feel very painful, and the swollen joint, and it's warm, it's tender, and then they also experience a stiffness after, like, probably wake up in the mornings or after inactivity for a while. And this is a common like deformity, as you can see it in the picture down here. People will either show the boutonniere deformity, that is like the hyper extension at the IP joint or the DIP joint, and then they won't be able to extend their PIP joint. And some of them also see you will also see the swan neck deformity. That will be do the opposite, that you will have the hyper extension on the PIP joint, and then you won't be able to extend your DIP joint. So I'm going to talk about some of the evidence that I found. So exercise and the splint are sort of the common OT treatment that we do for the people with RA. So for exercise, this part, I found one systematic review, but I will show that later. But something interesting that I noticed that for the high level evidence that I found for this exercise part, all 3 articles or 4 articles that I'm going to show you, they're also are from the UK. I don't know why. So this particular article published in 2006 is relatively old, but they have like 3 different groups. All the groups receive the joint protection education that includes, for example, the basic idea like energy conservation, and then some tips how to do daily activities, and then how to maintain the balance, all those kind of things, like basic protection education. The second group, they also include that they will also receive the stretching exercise. That will stretching including like small joint about their fingers, about their thumb, and then also wrist. The particular group one that is their focus on is the group also receive strengthening exercise. That includes, for example, pinch grip exercise or some like wrist extensor exercise to strengthen those extensor muscles. And what they found is that this particular group received all of them, including the strengthening exercise, showed better upper extremity function outcome at 6-month follow-up. And the next article, the next 2 articles. This is a really big multi-center RCT study. They total include almost 500 people. This study also is conducted in the United Kingdom. So they have this specific program called SARA that stands for stretching and strengthening for rheumatoid arthritis of the hand. So they have this program, basically they focus on a tailored home exercise. So that include, for example, they have mobility exercise and then strengthening and endurance exercise. They ask the patient to do at least 3 months, and then that's in addition. So I want to also mention that in addition to the usual care. And they compare this group with the control group who just got the usual care, which they got the joint protection education, like splint, something like that. What they found is in the 2015 article, they found that the group who received this SARA, strengthening and stretching exercise, they showed more improvement in hand function at 12 months follow-up. And further on in the 2017 article, they extend the follow-up time. So they found that this particular group also shows significant improvement compared to the baseline at 6 months. It's just unfortunately, they didn't find significant group difference. So at the 26 months, those 2 groups didn't show significant, but this particular one compared to themselves at the baseline, it has shown still a significant improvement. The last one is an RCT study, and they found they include total 7 articles. This particular one, they compare the intervention specific for hand exercise. That's also include the strengthening exercise compared to other non-exercise therapies. And then what they found is that exercise may not improve the hand function or pain or strength in a short-term period of time. So if it is less than 3 months, then we probably won't be able to see any specific effect or significant improvement. But if it is longer than 3 months, is a medium or long-term, then the exercise probably will show you some improvement. So to me, it's kind of interesting. So overall, the suggestion is strengthening exercise. This kind of like can provide the benefits to people who have the RA, but we probably won't be able to see the benefits immediately within the short-term periods. We probably need to wait until 3 months later. So I think that's kind of interesting to know. And the next exercise, the treatment part I'm going to focus on is the splint. So this particular RCT article I found, this published in 2008. They specifically include people who have thumb bottom-ear deformity secondary to the RA. So they asked the patient to wear this particular type of splint that actually allowed stabilize the CMC joint, but also the MP and CP joint, but allow them and then prevent them to hyperextend the IP joint at the thumb. And then what they found is compared to the control group who didn't have the splint, they showed that this particular group who actually have the splint showed less pain at the 45 and 90 days. And then they also showed greater satisfaction. It's just that these two groups didn't show any significant difference between strength and function, but this particular splint did help with the pain. The last article, also an RCT study, is published in 2009. This particular article includes enrolled patient with specifically the swan neck in the index finger. So they compared these two different types of splint. One is the silver ring splint and one is the oval 8 finger splint. They both groups wear the splint for 8 weeks. And what they found is that both splints showed significant improvements after 4 weeks. And then patients are preferred, like similar amount of numbers, patients prefer either of them. So the conclusion is that both of them are preferred and acceptable to the patient. So both of them are useful. And then they didn't show any particular significant outcome difference between these two. So overall, the conclusion is show that the splints are really helpful to improve people's function for people who have the deformity second to the rheumatoid arthritis. But there's no specific type of splint that is better than the other one. It's like people prefer either of them. And then the function, the benefits also pretty even. So overall, again, I just put both of them together so you can compare. For the exercise, people do suggest that strengthening should be included, and then the splint also should be included. I found also another article that is published 2017. It actually covers a very detailed systematic review for all the OT intervention for people with arthritis, rheumatoid arthritis. But this particular one, I didn't talk about it because it didn't just focus on the upper extremity. It also talk about the balance, everything. So they include exercise like the Tai Chi, yoga, all those kind of things. So if you're interested in treating people with rheumatoid arthritis, maybe that's the article that you can take a look. So overall, again, this is all the reference. And then the last one I was talking about is this particular references. And that is pretty much it for the part I want to cover for the rheumatoid arthritis. So any questions?
Thank you both so much. Anybody have any questions out there? All right. Well, thank you very much for attending this evening. Really appreciate it. That was a wonderful presentation. I learned some great things, and I think my favorite part about it was the integration of the COPM, and then looking at articles as well as how they're going to impact treatments for people. So please remember to complete your assessment at the end of this so you can get your continuing education. Thank you so much.
Hi, everyone. Thank you.
Good night.